I ask you to write your emails for whomever would like to receive the recording or the presentation, because the Zoom registration system works in such a way that I cannot unfortunately see your email, so that is the reason I keep asking you for that. And also a little disclaimer, some of you may know that EHDS is undergoing restructuring, and I cannot say you what will happen exactly next year with digital priorities, but I will no longer be working for the organization. So I remain available for you via LinkedIn if you ever have any questions linked with the European Health Data Space, or you would like to follow up. So you have my email for now, I'm there, but in the future, if something pops up and you have questions, I'm happy to answer to the extent I can, of course. So yeah, please feel free to keep in touch with me via LinkedIn, and I might see some of you on some other occasions in the upcoming weeks. But overall, yeah, that's the situation. So for today's session, it's quite clear, right? So they're going to be two parts. So let's start from the first. So secondary use is actually refers to the use of health data beyond its original purpose. So beyond clinical care in this context. So it's everything what is not clinical care. So examples can include research and innovation, public health planning, policy development, development of personalized medicine, and the list can go on and on and on. So it's not exhaustive. So whenever you hear also from me sometimes, and maybe during this presentation, I will also be saying data used for research. This is a simplification because secondary use can be much, much bigger than just research. So there are many, many things in there. And the great challenge is to keep the balance between the use of the data for all these essential purposes and to keep in mind all the ethical considerations which are coming together with the use of data for secondary purposes. So the benefits are quite clear. So it's just to kind of summarize. So for patients, of course, there is hope for better treatments through more opportunities for research and innovation. Also, there might be earlier and better diagnosis through AI use, for instance, for researchers. It means that they can access larger scale, high quality data sets, have better insights on the disease patterns, trends. Policymakers, thanks for data for secondary use, are able to have to make decisions based on evidence. Maybe to better allocate resources as well. It's very essential in healthcare to see actually like the data in order to understand how to improve it as well. And of course, for healthcare systems, there is a promise of better efficiency and cost effectiveness. So this we hear very, very often whenever it comes to uses of data for secondary purposes. There are also many, many challenges. Some of them have been tried to be addressed through the regulatory tools, such as GDPR. So to be compliant with the GDPR and other regulation is a challenge on itself sometimes, because there are many actually entities. Sorry, I have some kind of weird message from my screen saying that it wants to restart, but I hope I will not disappear now. So another issue is interoperability. So there are plenty of different standards and formats of data across Europe and also across the globe. And the European Health Data Space was created actually to kind of mitigate this challenge, as we spoke in the previous sessions, that there will be a common standard, which hopefully will increase data interoperability, at least between 27 member states. Informed consent is an issue, and also how to ensure that it's truly informed, and how to ensure that the access to data is ethical and also sustainable in a way. We will discuss in detail this issue a little bit later. And of course, the governance is also a big challenge, how to ensure the transparency of how data use, accountability, liability, and all of this. So partially these challenges, to the big extent, I would say, they're addressed by the upcoming European Health Data Space Law. But we will also have to see how it will work out in practice and what loopholes will happen there as well. So in order to understand the context better, let's start from the basics. So it's the General Data Protection Regulation. We also must keep in mind that it will not disappear. So the GDPR is still there. So despite the fact that there is a specialized law for health data, the key law remains the General Data Protection Regulation. And actually a lot of revisions from the European Health Data Space, they are just being an explanation of what already exists in the GDPR, especially when it comes to secondary health data use. For primary, it's a little bit different. There are many new things, but on the secondary use, the European Health Data Space Law heavily relies on the regime established by the GDPR. And some of you perfectly know that it's a very complex and not very straightforward regime, which is subject to many interpretations. So in a nutshell, health data is considered as a sensitive category of data under the GDPR. And in principle, you cannot process that data at all. There has to be a special legal basis. So the famous Article 9 of the GDPR is actually provides the basis for that. It's not the only article. There will be some of them mentioned. I mention all of that for you to have the reference in the future, where to go in case GDPR changes one day as well. So you know more or less where it comes from. So basically, the GDPR says that patient consent, which could also be citizen, consumer, user, well, not user in there, but individual consent, is a cornerstone of the legal regime, which actually protects personal health data. And in principle, without consent, the data should not be processed. This is a general rule. But the GDPR has quite a few exceptions to that. So in reality, it allows also for other legal bases than consent in order to process health data. And it also affects the level of protection to data and many, many other things. So one of the key legal bases to process your health data without your consent is public interest. So this public interest could be serious cross-border health threats. Here is a perfect example, COVID-19, when a lot of our data was used without us being asked in order to develop vaccine, to understand the situation. So I'm sure none of you were explicitly asked, maybe in some very rare occasions, for your health data to be used for these purposes. No, it was used extensively by different actors because it was cross-border healthcare threat pandemic. Archiving is also a perfect example of public interest, any kind of statistical, scientific, historical research, compatibility of scientific research. And basically, here comes the article of the GDPR 6.4 that in these situations, the data can be processed without consent. Not everywhere, though. So in some, the member states have freedom to decide that. So that is when we look in Article 89 of the GDPR, that they do have freedom at the national level, the member states, to modify certain rights of an individual. So for instance, right to access or rectify personal data, right to object to processing, whenever it's aligned with public interest goals. And all these rights in detail we went through in the second session. And I mentioned some of them, if you remember from a few weeks ago, that these rights are really not absolute. So some of them are, but some of them aren't. So that's why I kept telling you it really depends where you live on how these rights will be interpreted. So everything comes actually from the GDPR and from these articles. And you probably have heard it quite a few times from me. It's, again, very red line, like to remember that it's not because the GDPR is a horrible law. No, the GDPR is quite a good set of rules. The reason it is like that in GDPR is the agreement between the EU and member states on the division of competences. So it's simply the EU cannot have a law which will impose certain rules in healthcare for the member states. It's the treaties. So the GDPR looks this way, not because somebody did not think of that. Actually, in times of the GDPR, there was a lot of discussions and different types of lobbying to kind of harmonize this regime. But it is simply not possible, simply because the EU has very limited competence when it comes to healthcare. It's up to the member states, and it's just the reflection. And it's a reflection in the GDPR, it's a reflection in the European health data space. So there are some steps which are being taken in order to harmonize our approaches to research and data used for secondary purposes. But in the end, it is up to the member states, and they did not give up this right for now. And unless they gather one day and change the treaties, it will remain the same. So even if in the future the GDPR will be reviewed, or the European health data space will be reviewed, they will again be a reflection of what the EU can do and cannot do in this domain. So basically, yeah, it's a very delicate balance, and there is always a challenge to kind of have this balance between the data use and between transparency, individual autonomy, privacy protection, and so on and so forth. And it's really a difficult setup to interpret as well, because it differs from country to country. So there won't be one answer. So both the GDPR and the European Health Data Space and some other laws which are linked to that, such as Data Governance Act or Data Act, they are a reflection of this exact situation, and it will remain like that. So it will not be, there might be some more clarity, some more willingness between different states to be more harmonized, but overall, this is the situation which will be happening. So I have mentioned the public interest, and this is a very, very mysterious thing, I must say, because it appears very frequently in different laws. So in the European health data space, I cannot tell you how many times, because the text is still not finalized, it's not published. But in the GDPR, public interest mentioned 70 times, but there is no clear definition on what it is. So when you start to dig deeper, trying to understand what is the public interest, you come back to the same point as for the question why there is so much disharmonization between the member states when it comes to the uses of data for research. Basically, it's up to the member states to define. So it's up to each country to define what the public interest is. And there is nearly no reference in the EU law to have some kind of framework or definition of what it actually is. It is up to the member state. On one hand, this is very understandable because it's such a fluid concept that you cannot really define once and for all. And it's also something what is changing. So you might have a situation in your country where it would be in the public interest to pay attention to one or another thing in this particular year or in this particular period or decade or whatever it is. But then it will no longer be in public interest. Then something else might come up. But the question is, and it remains to be open, and despite a lot of requests throughout many years to actually, from different stakeholders, not only linked with public health, but in many other places, to actually give the framework, or at least to set up some kind of methodology on how to exactly define public interest, it did not really happen. So public interest is really, it's a very, very vague concept. So some of the things are very obvious, such as statistics, archives. Of course, it's in public interest. But when it comes to separating commercial versus non-commercial interest, for instance, it's not an easy blend. And this actually causes a lot of ethical considerations, and it's difficult to say whether it will be a fair exemption to use, for instance, not to use consent at all in some situations, but not in the others. So it's still an open question, and there are no clear answers in the European health data space. So one of the potential challenges on when the law will be actually implemented and interpreted, that it's so wide, this public interest definition, that it can be a lot of things in the end. And again, it might depend severely on the member state. So there are quite a few risks of not having such definition. So primarily for individuals, actually. So it might be higher privacy risks, because you might say that we use your data for the greater good, for public interest, and so on and so forth, but maybe not. So maybe it will not be true, and it would be very difficult to check, because you simply will not be asked whether you want your data to be used or not. It would just be used. But you, maybe personally, maybe as a group, and me as well, personally or as a group, might experience some kind of indirect effects, which we may not even linked with the fact that our data was misused, or something like that. So these risks, they remain, and they might even be higher in the future, because once again, we will be using much more data than we used 5 years ago, 10 years ago, because the whole new system is coming to facilitate that. If this happens, then of course there will be a tremendous drop in trust in the system and how the health data is governed. So hopefully this will be taken into consideration by all the stakeholders who are going to work on the implementation of the European health data space, to make sure that it's right, and that that nothing will happen, like very big, something will happen for sure, but nothing of super big, importance will happen in order to destroy that balance, and to go on the side where people would simply lose trust in the system. So this is why it's extremely, extremely important, even if it's not done on the legislative level, but at least to have better understanding of how to define how public interest is defined, maybe through new system, maybe by health data access bodies of the European health data space. So if your organization or you in your personal capacity work on that topic, please keep in mind for the future, if you are going to advocate for that this is a very, very important point to ask for, that to agree on what public interest is. It's important both at the national level, but also especially in the context of rare diseases. It's very important also in the cross-country region, because the data will be used in the common pot. So it's going to be, we're speaking about regional, international research, and so on and so forth. So it's very, very important. Tricky thing, as I mentioned, is the commercial involvement into that. Both GDPR and the European health data space and some other laws linked to that say that both commercial and non-commercial entities can use the notion of public interest. So when we're saying that data is used in public interest, we do not assume automatically that it's used by academic institution or somebody who does not seek profit. It's not correct. So it can be both industry, it can be both non-commercial interest, it can be blended. So it does not really matter for that, as long as they fulfill the requirements to be qualified for public interest. And as mentioned before, the requirements for public interest are extremely vague. Maybe they are defined in a more precise way at the national level, Maybe they aren't. At the European level, there is no such definition what exactly it is. Only very, very vague things appearing in sometimes even case law, but they are not pronounced in the laws we're speaking about today. So important thing to remember that data is used for public interest, both by commercial and non-commercial entities. It does not preclude them. But then the big question is actually how to separate, for instance, imagine pharmaceutical company who clearly matches the criteria of public interest. So for instance, they're writing a note request to access the data to develop a treatment for one or another disease. And it qualifies as public interest. But at the same time, it's not that they're giving up, any kind of profit they will make from that treatment, right? So they can both be of public interest, but there could also be clear commercial interest. The same sometimes is in academia as well. So they can both have commercial and public interest. And this blend and distinguishment between two is very, very unclear. So one of the things which we were advocating for during the European Health Data Space negotiation process, together also with some other NGOs, is to for benefits from the uses of secondary health data to be shared. So it comes actually from the Declaration of Helsinki. Again, if you ever decide to do an advocacy on that topic, it's a very could be a very useful piece to refer to. And it says that if medical research is done within a vulnerable group, this group should stand to benefit from the knowledge, practices, or interventions resulting from the research. Yet, whenever is data used for research, this benefit for the ones who actually have to benefit from that is often disregarded. So sometimes, yeah, it's asked from people from the group to give the data, but they may not even receive direct benefit from that. So maybe in the end, for instance, if we're speaking about the treatment is developed actually, but it costs so much money that the people who actually need that treatment cannot even afford it. So what was the point for them to give so much data for free, basically, because, or even like they were not even asked about that. So this data was just taken, something was developed, and in the end, we're having another webinar where we're discussing how medicines are not available and accessible. Might be the situation as well. So what is important to keep asking, some of the things are reflected in the European Health Data Space Law, not all of them, but there were some mechanisms which they put in place in order to make it a little bit better, to have this step forward sharing of benefit, but there is much more has to be done. And also with time, when the data will be shared quite a lot, there will be more benefit. And what is important to keep asking is to put some measures in place. So for instance, it could be taxation, where profits are made from research. The company, who benefits from that, they might pay the tax, for instance, to the government, or somewhere to kind of give back somewhere. It could be securing affordable access to the results of the research. So basically, the European Health Data Space is about that, not to hide so many things behind the closed doors, but it's a big step forward if implemented correctly towards better sharing of data, better sharing of results. And another means could also be redistributing economic benefits with individuals or communities and ensuring capacity building. It's a huge question, and probably we will not have time today to discuss that on how exactly to implement that and what is fair here. What if the data comes from the mixed data set? What about all these companies' research and design costs and many, many things? It is all very, very valid questions, and the perfect system was not created yet. But it doesn't mean that it's not a topic for the future to keep in mind and to keep asking to have certain giving back to the society. Of course, here we can also speak about data monetization in a way, and there are very different opinions of whether individual data should be monetized or should not be. In my personal opinion, it's quite a dangerous path to take, but at the same time, there should be other means to give back, and maybe not to a specific individual by paying them a certain amount, because then it's also, there is always a question, how much is it worth? How much worth is your data? What is the price tag for that? The answer might be, and probably it's the correct answer, that it's invaluable. So you cannot really put a price tag on something which you don't know which benefits it could bring, for instance, to the company. So for instance, they might offer you, I don't know, 50 euros, and for some people it will be good enough money, but in the end, what if they make 50,000 euros from your data set? Is it a fair compensation? Is it not a fair compensation? How much? And things like that. Again, tons of ethical considerations, and also whether it will incentivize some people who should maybe not contribute with data at all to do that. So plenty of moral dilemmas here. Yeah, and this is the first part on understanding of how actually the regulatory framework works is over. So before we jump to the next part, which is actually speaking about the European Health Data Space, I will stop here and answer any of your questions, and maybe something was not clear, please feel free, and I will look to the chat briefly.
I think Dan has his hand up.
Please go ahead.
Yeah, thank you. Thank you, Jelena, for this overview. Ever since I've heard about secondary health data use and commercial interests, I've been struggling to get my head around the idea that, one, pharma companies will share any data at all, and most of all with patients, but then also maybe with other competitors. And then if they do that, they would not do this for free. So I just can't figure out how we could avoid monetization of data. Do you have any thoughts on that?
I don't think we can avoid monetization of data, because the only way is not to allow commercial actors to access it at all. So to completely tell them you have no access to this. But then I'm more speaking, about the individual, how does it impact individual? Because some countries want to encourage people, for instance, to give their health data by just simply paying them money. Of course, there will be data monetization, and also in the European health data space, it's extremely clear, and it's not new as well. It existed in the GDPR as well, that commercial actors can have access to data. Very important thing, they cannot have access to your primary data use, so they cannot access that. Whenever it's between patient and the doctor, unless you allow it yourself, there is absolutely no way for them to use that. But secondary, yes. And actually this whole idea behind the health data space is also to boost the economy. So of course we are speaking about data monetization, but what does it mean for you as an individual? Do we start, so how would it work on the market? So do we treat data as a good, which you may want to sell to somebody? Which price are you going to put it? Is it ethical to send your data as well? For some people it will be yes, and for some they will say no, it's not ethical. I don't think it's preventable, because actually all of our data is monetized. So our activity in the internet is the monetization, and there is a good saying that if you are not paying for the product, you are the product. So I think this is the reality we live in. So yeah. Miriam, I think you were next.
Yes, thank you, Elena. I would like actually to bring the question at the higher level and not at the individual data. Working for a rare disease where we do have registries for data and some industry partners would ask individually for access. Is there like a mechanism or sort of SOPs that would be available or can be available so all patient organization having data registries would be able actually to work in parallel with all these stakeholders and not only raising on monetization for free or not, but just like a mechanism where this data can flow in a more simple way that like there's no concern for the economics, but there's a sense from the patient community themselves that my data is valuable and not exclusive to one or other. And maybe this comes back to Danielle's question as well.
It's a very good question, I think, with no simple answer, because in theory, it's the European Health Data Space who's supposed to kind of create this ecosystem where the data is kind of shared and it has value. And indeed, there is a lot of willingness to make it as ethically possible from the Commission side to create quite a reliable infrastructure where things are not misused. But in practice, I think it's extremely difficult, especially when it comes to registries, that sometimes, there is a lack of funding, independent funding. Sometimes it's one of the aspects to keep the registry going, especially if it comes as an initiative, of a group of patients. And another big problem is actually the interoperability with other sources to make sure that the data is of good quality and that there is a use of the same standard, which would allow to kind of exchange the data. So for instance, it would be extremely valuable actually to have data from the patient registries, for instance, somehow, maybe analyzed together with the electronic health records of the population. Maybe combining these two data sets would lead to, I don't know, enormous scientific discoveries, but how to make sure that these two data sets are actually compatible and are of equal quality is a very, very good question, which comes usually back to the question of money. So if there are not enough money, you cannot really collect and ensure that the standards are used and things like that, because it's very expensive. So it's not something which, you can, take out from the pocket and say, I have it now. No, it's an investment, but then, again, if this investment comes from private interest, whether the private interest is willing to do that, maybe yes, maybe no. So hopefully in the future, it would be more streamlined. I don't know if it answers your question.
Well, thank you. That's helpful actually to brainstorm all together and think about the path forward. I mean, we all know there's no simple current answer yet to the question. Thank you, Elena.
Thank you. David, I think you're next. Or David, I'm sorry.
That's fine. Thank you very much. Very, very interesting. And I just wanted, first of all, just for you to a point of clarification. When you said that the doctor-patient data was only available with your consent, is that a GDPR issue or a medical confidentiality issue?
Both. It's both, but basically we're speaking.
I'm struggling to see where it's a GDPR issue that you have to have informed consent for the use of your patient data. So under Article 6, it's you have to have one legal basis. Now, common practice might be that we do that by virtue of informed consent, but equally it could be because of the contract you've made with the doctor. Because often our data aren't, with our relationship with the GP isn't often negotiated as a GDPR thing. But I'm just a bit puzzled as to where you can say that it has to be by informed consent?
In principle, so it's the main data processing ground, but there could be other legal grounds. So then it depends on the country. So it really depends on the national level. So in some countries, there might be a clear requirement, which is allowed by the GDPR. That's why I'm saying it's both, because GDPR, when it comes to sensitive data categories, it gives a lot of actually freedom and leeway for the member states how to determine that. So they might ask for the consent based on the GDPR. So use the GDPR as the legal basis to do that. And they may not use the GDPR by using, well, they will use the GDPR, but they will choose the other legal basis. So it's actually the situation in the member states. And in some places, they will say, yes, it's a medical confidentiality, patient-to-doctor relationship. In others, there will be another context by which they say we are choosing this rule because XYZ. But basically, what I'm saying that GDPR provides basis for that, but how exactly member states are using it, it's up to them, because GDPR gives them freedom to decide in there. Once again, it's linked with the fact that there is a competence limitation for the EU to have it. That's why GDPR has all of that.
Okay, thank you very much.
Thank you. Marta?
Hi. Since I work for Portuguese tax administration, I'll be talking now about taxation.
Mhm.
And it's an issue that it comes to me because I'm on it for working. So I want to put on discussion that this is a complex topic on taxation, especially in commercial ventures, and especially when research is funded or driven by public money. This taxation measure could encourage a more equitable distribution of the rewards that come for successful research, but the key principle would be that commercial entities that profit from research, particularly when this public funded is present, they should be required to share some of the profits with the society. And examples that are given is further research, public health, somehow improvement, or innovations, parallel innovations. However, this also raises concerns about the impact on innovation, as you may understand, because if you have a tax, you may get away from the research at all. So over taxation, or even taxation when before there weren't taxation, can discourage from research, and that must be a balance between incentivizing private investment in research and ensuring that it's a fair sharing of the benefits that come from it. So I believe that some measures could include to consider how to define profit, because it's taxation goes on profit. So what is profit, especially when the research is public funded, because they can have profit, but only because they have public funding. So maybe defining what is profit in a commercial venture with public institutions, and maybe divide in fields with high development costs, like pharmaceuticals that are more expensive and less research on that. So maybe we can define profit and define profit for specific grounds.
Yeah.
So in short, taxations can be part of a benefit sharing ecosystem, but they must be designed in the way that can be done, because just doing that without measuring all the consequences and
Absolutely. Yeah, that's why it's not in the law. Because of all these complications and yeah, actually defining what is profit could be very helpful. But these are the issues which will remain. So it's something just to reflect for the future as well, because not everything is solved by the current law, and it's not going to be a forever law as well. It's going to be reviewed, and there will be a lot of problems. Maybe not problems, but the questions on how to make the system work better in the future. And I think this, like whenever it comes to all this, monetization of data, balancing between commercial and social benefits and all of that, it will be becoming bigger and bigger. And I think it's, for now, while it's still in the implementation phase, it's a very good moment, I think, to reflect on how to address these issues, because it's true, yeah, it's really, a lot of MEPs were supportive, members of the European Parliament were supportive of this idea to give societal benefits from the European health data space, but it's very difficult to implement it in a fair way. And yeah, and as you say, yeah, what is profit actually, how to calculate it, and there is no black and white, that sometimes it's a public data and public money, but sometimes it's a mix. How do you separate the mix? On what do you put taxation? On which amount? Yeah, these are all valid questions, but saying that it's not, but completely ignoring this topic could also lead to the situation where people would be excessively contributing with their data for the development of new products, services, better everything, but in the end, they will not necessarily see these benefits themselves. They may not feel that, or these products and services will be so expensive that, yeah, they would need to run a crowdfunding to allow, themselves to access that. So it's this balance where it's just, there is so much talk about how much data is linked with economy and how much money it will bring, but unique to health situation is also that health is, yes, it is about money in a way, but it's also about lots and lots of social and human questions and ethical questions. So that's the key.
and the public interest. Again,
Absolutely, yeah.
public interest.
Yeah. Okay, so
Yelena, there is another question in the chat. Pavel, would you like to ask this question directly? It's about trade secret and public interest.
I'm just reading here.
Oh, okay.
Yes, it's possible. There will be a bit of part on this IP rights and trade secrets in the second part of the presentation, but in principle, yeah, it's possible to withhold certain data on this basis, whether it's intellectual property right or it's part of the trade secret. I will explain it actually, like in a few moments. We will come back to that. So if no questions for the first part, then I will go on, and I believe we will still have some time for the discussion in the end. Okay. So now we're back to the European health data space and how it's actually going to work. So we discussed the entire system in the first session. So if you would like to come back, I invite you to view the recording or go through the presentation again. Today is more focus on the secondary use and some specific provisions there. So the most important actor there is the health data access body. So each member state must designate one. Some of them already have them. So in French, it's Data Hub. It's exactly the health data access body. And in Finland, it's FinData. You might have heard about them. So in other countries, there will be their own. These are two, the most famous one, which exist already. So basically, these health data access bodies, they will be responsible for deciding on data access applications They will authorize and issue data permits, and they will provide access to electronic health data, and they will also monitor and supervise compliance with the requirements of the European health data space. Very important entity. They will play a very big role in all this system. So how it will actually work? So holders of electronic health data will be required to make their data available to health data access bodies. And then in turn, health data access bodies should make it available in the platform. And then data users will come and ask for the permit. So the data users, applicants who seek to access the electronic health data from more than one member state may submit a single application to one of the health data bodies of their choice. So they can choose. It's not like if you live in Luxembourg that you only can go to Luxembourgish. No, you can go to different ones if you want data from several member states. So in principle, it's only anonymous data which will be made available for data users. And the goal is for data anonymization to occur as early as possible in the chain. So probably it's already the data holder who will be anonymizing the data, but it will depend. In some exceptional cases, the data user may seek to access pseudonymized data instead of anonymous. And as we know from the previous sessions, we're here speaking about personal data. So some personal identifiers will be removed, but in principle, it's personal data. And in many, many cases, when we're speaking about rare disease, we will be speaking about pseudonymized data, because here, of course, like when we speak about any types of genetic data, it is always personal. So in some cases, as an exception, it is possible to access also that. But we're coming back to Article 6 of the GDPR. The data user must have legitimate interest to access that data. And from what we remember, we're coming back to the point of, for instance, public interest, and whomever qualifies that. Again, this issue remains. Public interest might be both good and bad, but hopefully, yeah, there won't be any serious misuses there. So the data user, the ones who would like to seek access from the data, what do they have to do? So they need to fill in data access application. They need to identify who they are, their professional function, natural persons who will access the data. So if it's the entity and organization, they need to name the names of people who would actually access the data. So it cannot be the entire organization with 100 people. There should be names of natural people in there. They need to clearly explain why they're using this data, what benefits they expect to receive from it. So for instance, if it's in public interest, research, innovation. So as you can see, the benefits are not limited again to public interest. Innovation is very clearly a commercial interest. So it can be a commercial interest, but let's say they described it as bringing innovation. Another very good question to reflect on: what is innovation? But it's probably the topic of many other discussions. Then they also need to describe the data. So scope, time range, format, sources, geographical coverage. If multiple member states are involved, it should also be described. So they actually need to say what exactly they want. They will see it from data catalog, as we discussed in the first session. So there will be the place where you could see what data is available. So it's an easy requirement, because the catalog will do it for you. Then they have to specify in which format they would like to get the data. Is it pseudonymized or anonymized? If it's pseudonymized, then of course they have to give a justification why it is so, and they need to demonstrate the compliance with data protection requirements. Then they need to clearly define safeguards against the data misuse, what exactly they do to prevent, for instance, re-identification. So yeah, maybe, yeah, it depends. Probably it's going to be some technical specifications which have to be explained on what it is and what measures they're taking in order to protect data holder as well and individual rights. So in principle, all these things have to be thought through, and there should be clear policy within the organization on all these matters, because it's not that anybody can join and say, yeah, I'm this and that, please forward this file to my WhatsApp. It's not going to be in that way. So it's quite a serious process, which they have to submit quite a lot of data and also think about different safeguards and yeah. And of course, there is a need to identify the processing period of for how long they would need access to data. This is also a requirement in line with the GDPR, which always says that the data should not be kept longer than necessary. So it's in line with the principles of data minimization, and it's also quite a good safeguard to have a time limit. Then it's easier also to monitor actually if you don't give up data to somebody to forever, then yeah, it's easier to know at least who has access. Yes, I think I see Daniel's hand. Please go ahead.
Yeah, just a quick question. When you say get access to data, does that mean they can download a copy of the data, or they would be able to access it, work on it, and the data doesn't leave the place where they are? Because obviously that would give some sort of protection against misuse and reselling maybe the data.
Mm-hmm. That's a very good question. I don't know an answer 100%, but from what I understood, it's the data which will be used on the platform. So it's not that you can download it and go with copies all over the place. From what I understood, it's not the case, but also how to prevent it, I don't exactly know, because yeah, that's a very good question, and I think we should ask the ones in charge of the system, how would actually, yeah, what preventive measures could it be in order for them not, to copy the data? I don't know. For instance, it's on the screen. I can take a picture with my phone of this data. So what are they going to do with that? Very, very valid question.
Hi, can you hear me?
Yes.
Yeah, about this data, where the data will be put, it's actually a secure processing environment.
I don't hear you very well.
It's actually the secure processing environment where the data is supposed to be held. Then they make that request. So did you get that part?
Can you repeat your question or type it, because the sound is very poor and I don't really hear you.
I was saying that when the data is requested, the platform that it's kept in is the secure processing environment.
Yes. Yes. Yeah.
Okay, so related to that platform, I have a question. So if the applicant requests data from multiple member states, which member states SPE will the data be held in?
I don't hear you really well. I'm very sorry. If you can type the question, I'm happy to read it, because I don't know, there is some kind of issue with sound. Unfortunately, I keep not hearing you really well.
So I sent the question via chat.
He wrote it on the chat.
Just a second. Sorry. Now I don't know how to access the chat here. The data is never held in anyone's, so the data is always on the platform, and the platform is not centralized, so it's a decentralized system. So in principle, nobody can have the data on their SPU or anything. So it's linked with the question Dan asked, how to prevent the data migrating somewhere else. But the idea is that data is circulating only within the created infrastructure, and it's a decentralized system. So if somebody requested, in principle, they cannot, hold it somewhere. But this is something I have to to actually ask the ones who developed the system how it's going to look like, because we have not seen it yet, how exactly it is. But yeah, it's very, very good point. And it's also very much linked, of course, with secure environment, how to ensure the security of it. So if I hear something in the next days, maybe I have a chance, actually, tomorrow I'm in the event where these things might be discussed. So I will write you a note if I learn something on emails together with presentations on this. Oh, no, I have to start from the beginning. Sorry. Okay, yeah, processing period is repeated twice. Yeah, and the applicant has to say how their environment is secure. There will be an obligation to share the data. So data holders who receive the request from their health data access body to share data covered by the European Health Data Space, they must provide the data to the health data access body within 3 months. If it's justified, it can be extended by another 3 months, but in principle, it is an obligation to do that. After that, the data is available in the secure processing environment of the European Health, of the Health Data Access Body, in anonymized, and as mentioned before, in some situations in pseudonymized format, and yeah, if the justification is there. When it comes to data users in third countries, so whomever is outside of 27 member states, they can also make an application to the Health Data Access Body, but it only applies if their country is participating itself in the European health data space. There will be some specific decisions made by the European Commission that they provide equivalent data access system and protection. We discussed it in the first, I think, meeting before, that if the regime of the country is compatible with the European data protection regime, in principle, it's likely that they can access the data, and also there might be some data exchanges between third countries. So it's one criteria, or the European Union applicants have access to the data of that third country, so whatever they have. So there is some kind of exchange. So in these situations, they might also agree, but this is all the subject of the decision by the European Commission, whether such accesses would be allowed or not. But it's very important also in the context of rare diseases, because global data sharing is encouraged, and exchanging data sets outside of EU would also be of very big importance. But again, a lot of criteria have to be met in order to ensure that. But in principle, it is possible. This, I think I shared with you already, but just an overview of what could be included in the data sets. So it's electronic health records, genetic data, biobanks, data from wellness applications, clinical trial data, but only when the trial is ended. So no data will be published or requested of ongoing trials. Data from medical device, data from registries, different research cohorts, surveys, and things like that. Member states can also add different data categories at the national level, and they are also allowed to introduce stricter safeguards. So for instance, they can ask for opt-in consent for certain data categories. For instance, for genetic data, they can do that for data from biobanks and some other things. So once again, we're in the situation where member states do have quite a lot of rights to manage the way they want to add additional data categories, maybe to use stricter rules on access to certain data categories. So there is an element of harmonization, but there is also freedom remains for the national systems to do extras, or to do it a little bit different. So basically there is no clear limitation in time explained in the European health data space. So the data before and after the European Health Data Space is the subject of the European Health Data Space. So it's not only the data sets which would be created as of next year, but yeah, it's everything what exists basically and is subject of the data categories which might be available. There are some fees involved in all these processes. So health data access bodies and data holders, I think only trusted data holders. We discussed the distinction between these two in the first webinar. They may charge a fee to data users to make data available, including for assessing their application, for the collection of data, preparation of it, if they are doing anonymization of that data as well. And the fees must be in proportion to the cost of making the data available. So it should not be some kind of, price outside of the blue, but it should be quite clear why they're requesting this price. And they may also include compensation for the cost incurred by data holders. And then data holders should provide an estimate of this cost to their health data access bodies. It's up to the member states to decide reduce the fees for certain data users. So for instance, if it's a public body, university, maybe a patient group as well. So if it's a non-governmental organization, it might also be, but again, it's decided on the national level who exactly they would exempt from the fees. For the moment, it's not very clear from the text on, so it basically allows member states to introduce the fees or to, make rules on whomever is exempted from that. Also, it's not very clear how it will impact data holders. Do they need to necessarily have the fees? And unclear. So this is something which maybe will be more pronounced at the national level. Maybe there will be some additional guidelines or something in the implementing acts, but for now it's not really clear how the system of the fees will be organized, but it will not be that they do not exist at all, and this is for free, because of course there are certain understandable costs. So for instance, if indeed the access body does anonymization process for you, of course it's not for free, so that's quite natural, but it should be very clear and proportionate, so it should not be something out of the blue. So again, very discussed topic, which touched a bit on it in the first part. There is a right to opt out from secondary data use introduced by the European Health Data Space. It is reversible. So a person may decide to opt out, but they also can change their mind and opt out or opt in. No, sorry, decide to agree for the data use. And basically, it's up to the member states to set up mechanisms to do that. And how exactly the individuals will exercise their rights. In that sense, it would depend on where you live. Also, member states do have some freedom to disregard patients' decision to opt out when it's necessary for public health, when there is serious cross-border health threat. Sometimes for research purposes, unmet medical needs, also it includes rare diseases, emerging health challenges, or anything like that. So they can override that. But again, it's not very new. This is the same as we discussed in the first part. It's the GDPR who allows to do that, and it's normal. So it's fine. The most important part that it's not misused and that it's justified. Again, if we look, at the situation which was happening a few years ago with COVID-19, there was a lot of excessive use of data, and in some countries, there is still an ongoing debate whether it was proportionate, whether it was necessary, and things like that. But this right exists. How it is exercised, another question. Some countries might be, overdoing it sometimes. There is also no indication in the text on how granular the level of opt-out should be. So who will manage it, how, and yeah, member states may rely on health data access bodies to do that, but they don't necessarily have to. They can also, and this whole situation can lead to very diverse approaches once again. So it might be a big mess actually when it comes to the implementation of the provision on opt-out specifically. It's not very clear also how opt-out will work on the data which is collected before the European Health Data Space entered into force. Again, maybe it will be defined in an implementing act, maybe it's up to the member states, but it's not really set out right now in the text, and it might be quite difficult actually to implement it on certain data sets, for instance, if the clinical trial data is ongoing and things like that. So yeah, a big question, but again, if you are interested or if it's relevant for you, watch out what is happening at the national level. They do have a lot of power to do that. Big win is IP protection. So previously, I think I mentioned somewhere that a lot of entities are withholding the data based on the intellectual property rights and trade secrets, and this question was already raised today as well. Sometimes these regimes are misused. So there is a certain explanation of a regime on how IP protected data and trade secrets data measures should be interpreted by health data access bodies, and how to prevent the misuse of this nose, let's say. So that's a very, very good positive step. Not super clear how exactly it will be implemented, but I assume there might be some specific methodologies or guidelines, agreements developed by the Commission or within the health data access bodies who would specify this process quite in detail. And yeah, so it does not mean that anything in IP rights or trade secrets laws is changing. It does not. It's just that there are extra measures put in place not to allow these excuses, when they're just excuses and not a valid point, to be misused in order not to share the data. And another important point, if researchers using the data from acquired through health data access body, they find something about the health of a patient, which data was used in the research, they have an obligation to inform health data access body, and then the respective health data access body may inform the trusted data holder, who then must inform the patient or relevant institution, hospital, and so on and so forth. So it's not a very straightforward line, as you can see, but in principle, this obligation is really good, especially when we have pseudonymized data. Sometimes they may not even know to whom this significantly clinical finding would belong, because yes, the data might be anonymized format, maybe pseudonymized, but they would not know exact person. But there are steps which will tell them to come back, and the one who is actually having the data maybe in a personal way, then they have an obligation to inform patient about if there is any health concern or something significant is found. And here I stop. I thank you very much for the attention, and we are back to the questions. So we have around 15 minutes for that. So the immediate question is in the chat, how these clinically significant findings can be shared when we're working with anonymized data. Very good question. The thing is that data can be de-anonymized, so they might, depending on the situation. So now we're speaking about hypothetical situations. So if there is something very clearly appearing as a tendency, so leave aside rare diseases, but for instance, there is some kind of, I don't know, poisoning situation or something, is identified in the group research. some common findings. So it's anonymized data, but maybe it's something which is very evident for the group, not for the individual. Then they do have an obligation still to inform, and then the whole chain of this access will come back to the data holder, and data holder most likely will have the data set which is not anonymized, and then they do have an obligation to inform people about the finding. It might not be very personal as well, and maybe if it's checked, it would not be relevant for that person, but there is this obligation of, giving an alert. But each situation would be different, and in some anonymized data situations, it would not be possible, and it would be maybe clinically irrelevant finding if it's not linked to anyone.
There is another question from Pilar a bit earlier. If the data are being used for an active research project waiting for publicating the results, is this enough to justify that the data cannot be shared?
I don't know the answer to this question. I think it's rather a no than yes, but here again there are several components which might be helping to identify whether it's yes or no. So if it's something linked with intellectual property, then it might be a basis not to share for the moment. If these findings are not confirmed fully, maybe yes as well. So it really depends. They do have a very clear indication only for clinical trials. If it's a research project, I don't know. And also what is considered, finished project. So maybe it will last for 20 years and people will just not share the data because they're waiting for it to end. So in principle, everything works in such a way to encourage early data sharing. So it might be that, it's a yes rather than no, but it depends. Yeah, the slides will be sent. I will save the chat and I will send you both. Yeah. Mm-hmm. Yeah, a question. Yes. Yes, you're understanding it correctly that the data will be shared through the system, which is created by the European Commission together with the member states. So it's the infrastructure. What I mean by data not leaving it is that most likely it's not possible to keep it on your own computer somewhere else. So the data should be used within the system. This is what I mean. But it might not be one single website or whatever, not necessarily. So it really depends how exactly. There are different elements of the system. So there will be different platforms, different infrastructures. So we're speaking about the fact that this should happen within the integrated infrastructure, not on someone's private servers. Yes, exactly. So they do have their own places, and actually the idea is that the data points, they're linked, they're not pulled into one. So what European Health Data Space is actually creating the link between the different storages of data. So also we're speaking about the registries, biobanks, and so on and so forth. 1 million genome project, which is run. So it's the fact that they're becoming interconnected. It's not that they will have one big place, but I'm speaking about the infrastructure which links them. It's not one common place, no, but it's like a house with many different doors, and indeed these doors will exist at the national level, and not one but a few. So it's interconnectedness between this is what I say mean by not leaving the system and using the infrastructure, if it makes it clear. Okay, anyone else? Okay, I think then we're done 10 minutes earlier. Thank you so much for your attention. You will receive the slides and the recording probably in the next days. And as I mentioned, let's keep in touch via LinkedIn who wants to keep in touch. And yeah, if something throughout next months, years will come up with this about this, please don't hesitate to contact me. I will try to help you out.
Thank you. Bye-bye.